Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Block 9, Trauma, Episode 2, Assessing the Geriatric Trauma Patient. After viewing this episode, participants will review the Geriatric Specific Trauma Assessment. Participants will review how to differentiate between chronic and acute injuries. Finally, participants will review pitfalls in assessing the geriatric trauma patient.
Trauma assessment always begins with seeing safety for the provider, safety for the patient, universal precautions. Then you're going to assess their level of responsiveness, their airway, their breathing and circulatory functions. Is their airway compromised or patent? If not, how are you going to manage that with different adjuncts? Are they adequately breathing? They have diminished abilities to compensate for being put on a backboard, so you have to be very careful to continuously assess their breathing efforts and monitor their oxygen saturations and such. Circulatory wise, you have to look to see, are they losing blood in a broken hip or broken femur? Is their heart rate corresponding to the blood pressure that you're seeing? If not, are they on a medication that's causing their heart rate to be diminished? So you have to be very thorough with that. Then they have most geriatrics tend to minimize the things that they have. So you have to be very thorough in determining what their pain response is, any physical findings that you find through a detailed physical assessment. They may not tell you that their leg is broken.
The first thing in geriatric trauma assessment is to ensure the scene is safe. When evaluating the airway, make sure it is patent, or do you need to use an adjunct or advanced airway? Evaluate breathing to see if it is adequate. Remember to continually assess breathing. For circulation, evaluate for internal bleeding and severe wounds. Geriatric patients tend to minimize injuries.
I think the thing that you have to remember in an older person is it's easy to get distracted by, oh my God, it's a 90-year-old. So going back to your fundamentals, doing a full physical assessment of the patient. The thing that makes it challenging in an elderly patient is that they have some baseline issues. In an older patient or in a younger patient, you could lay them completely flat, put them on a backboard. They have a kyphotic spine. You can't lay them completely flat. You need to end up padding that back. You need to do some other things. As you're examining them, you have to remember to sometimes speak loudly. Look them directly in the eye. They may not be able to see you. They may have either hearing aids or other assist devices. Most older patients have dentures. Don't forget to take them out if there's any concern about the safety of that person's airway. Other things about examining elderly patients: if you see a physical finding that seems abnormal to you, asking the patient, is this normal or abnormal? Keeping in the back of your mind that all abnormalities are assumed to be trauma related until proven otherwise, and you may not be able to do that in the field.
When completing a trauma assessment, it's important to complete a full physical exam. Older adults need to be moved and assessed differently than a younger individual. Position on a backboard or other devices can exacerbate issues. Speak loudly if the patient is hard of hearing.
I think the safest thing is to assume that it's an acute injury until proven otherwise. Ways that you can distinguish: musculoskeletally, if someone has deformed hands but they're not painful, likely that's not a new injury. The other thing, as you're dealing with elderly patients, you can have abusive situations where you may see a range of injuries where you have new and old bruising, etc. Asking about history becomes important. In someone who's demented, it can be exquisitely difficult to determine what's old and new. If something looks abnormal, it's non-tender, likely it is chronic. If something looks abnormal and it's tender, likely it is acute. From an abdominal exam standpoint, abdominal pain always should be assumed to be acute. Some may have chronic pain, but that can get exacerbated. And what we at least teach our residents is just because someone's demented or crazy doesn't necessarily mean they don't have real medical problems. On their chest wall exams, I think kyphosis of the spine tends to be old. It takes a while to do that, and the same is true in the cervical spine as well, in the thoracic spine. but anything new and painful is assumed to be acute.
It is a challenge to distinguish acute versus chronic injuries in geriatric patients. Abnormal physical findings in the presence of pain should be considered trauma-related. Patient complaints should be assessed regardless of dementia or cognitive disorders.
Well, you try to determine what caused the trauma injury. If they were walking and had a fall, were they dizzy or sinkable prior to the incident? Was it witnessed by anybody else? And also look at your vital signs and such. They may have a simple fall with no apparent injuries, but their blood pressure may be hypotensive, and that could be due to a variety of reasons, such as a GI bleed that they haven't discussed, and that would cause them to get dizzy and fall. So you have to look at what came first, the hypotension or the fall, and same with motor vehicle accidents. Are they having chest pain? Are they having problems breathing? And did those things occur prior to the incident in which they inflicted the trauma?
A lot of that comes down to the history in focusing on both falls and motor vehicle collisions. Was there an antecedent event? The person felt lightheaded. The person felt dizzy. Did they have a stroke or a heart attack before they fell or crashed their car? At the scene of an accident, are there skid marks? Did they swerve? Did they head, were they noted to be driving erratically prior to the crash? All things that would make you worry about a medical event occurring before they crashed. Other things that would make you concerned about it being a medical event leading towards another issue. Do they recall anything prior to that? Do they recall an aura or something else before they fell? Do they have an acute change in medicines? They just get started on 3 new blood pressure medicines would make you worry about a medical condition precipitating their trauma event. But ultimately, that ends up getting determined once they get to the hospital. It's sometimes very difficult to tell, did you have a heart attack and then crash your car, or did you crash your car and now you have a blunt injury to your heart? That can take 48 hours to truly elucidate. So some of that you really can't evaluate in the field. But most of it comes down to the history of what happened. Was there an antecedent event? Did they feel a funny heartbeat? Did they feel lightheaded? Was there anything different? And those are all important things that by the time the person gets to the trauma center, they either A, may not remember, or B, may not be alert enough to remember, and you may be the only one who knows that information.
In geriatric trauma patients, it's important to complete a history and assess for possible antecedent medical events. Such events include syncope, dizziness, hypotension, difficulty in breathing, chest pain, and GI issues.
There are 2 main pitfalls that EMS can really encounter in, well, there's a million, but 2 big ones that EMS can fall into when evaluating a trauma patient in the field and bringing them into a trauma center and missing things. Assuming that their vital signs, which may be normal for a 20-year-old, are normal for them. What you're really looking for is, is this patient stable? Well, death is a very stable state. It doesn't change. But are these vital signs normal for them? Is this mental status normal for them? So if you have someone who's demented, who normally doesn't recognize things, that may be at their baseline, but you always have to keep the suspicion that this isn't their baseline. You have somebody who normally you have, luckily, a lot of older people have their little medication list or their pill bottle or something else that's usually on 3 different blood pressure medicines, and their blood pressure is what would be considered normal for a 20-year-old. You have to worry that that's not normal for them. So failure to recognize significant injury based on vital signs that look stable but may not be normal for that geriatric person. They're not tachycardic because they can't be. They're on a beta blocker or the olol medicines, as they're referred to in GEMS. And blood pressures that may be normal for a younger person that aren't normal for that particularly elderly person. The other thing that is a pitfall is the immobility and difficulty in examining a geriatric patient and being able to assess acute versus chronic illnesses, and the assumption that physical findings are chronic where they may be acute. And this happens also in the hospital setting, not just in the pre-hospital setting.
Common pitfalls in assessing geriatric trauma patients include failure to recognize injury, unable to differentiate between stable and abnormal vital signs, such as blood pressure, and finally, to differentiate acute versus chronic injuries in the musculoskeletal system or changes in mental status. After viewing this episode, participants will review the geriatric specific trauma assessment. Participants will review how to differentiate between chronic and acute injuries. Finally, participants will review pitfalls in assessing the geriatric trauma patient.